Hi everyone, welcome back to UWorld Live and Learn. Sorry about the delay. I think we know Facebook and Instagram were kind of having a little bit of technical problems. My name is Valerie. I'm taking the place of Jackie this week. Thank you for having me on today. We're going to take a quick minute, let everyone log on to their streaming service and get settled in. We appreciate y'all being patient with us and patient with everyone else. It's the month of March now. Welcome to spring. If you're in school, you've got spring break, mid-semester exams coming up. Stressful time, I know, but spring break's right on the corner. You've got big things to look forward to. Hopefully you've got spring break plans coming up. So if you've got any big plans, leave them in the chat. Let us know what you've got going on. I know when I was on spring break, I'd always go back to my family, would go travel, go home, go to the beach. We live by the beach, kind of. We really appreciate y'all coming in during this time and taking the time to listen to us and maybe learn a little bit today. We know it is stressful that you have a lot of studying going on. Let's see. I think we're good to go. We can go ahead and get started. So, like I said, my name is Valerie. I'm a registered nurse, part of the UWorld nursing education team. My clinical background is in neuroscience and neurosurgical intensive care. Whether you just started nursing school or you're just graduated, I think UWorld's a great product because you can either use it to supplement your education or when you graduate to study for the NCLEX. So whether you're about to take your NCLEX or you got your mid-semester exams coming up, UWorld really is versatile. I know when I was, whatever study type you are, the way I studied in school was all over the place. I would spin in my chair. I was very all over the place. But the study questions were awesome because I would just sit down, take a couple questions. It was really helpful because I could just 20 minutes, set my timer, do the questions, look at the explanations, and learn a lot. So it was awesome. If you have any good study techniques, study tips, or a certain way you like to study, or you study tools that you use on UWorld, leave them in the chat below. Help out your other students out there. It's really helpful for people. Okay, so our topic today is delirium versus dementia. It's really easily mixed up because not only are the words super similar, but they present very similarly. So during our time today, we're going to talk about what causes it, the risk factors, how it manifests, our nursing interventions, and then throughout our topic, I'm going to compare side by side with dementia to delirium. So we'll draw those comparisons, okay? Later this month, we have an Alzheimer's disease Live and Learn planned. So tune in then if you want to learn more in depth about dementia and Alzheimer's disease. And make sure if you have any questions or any topics you want covered, go ahead and comment on any of our social media channels, your favorite one, and let us know so we can go ahead and plan for that and address your concerns or questions or any of the good stuff, okay? Okay. So let's see. And I've got the chat here below, so I'll try to tune in to whatever y'all are saying, okay? Okay, and then make sure while we're on the chat today, go ahead and leave any questions or comments about anything I'm saying or teaching. If you have any confusion, we'll try to address it. And then we'll have some interactions, okay? So our question of the day is going to be as follows. The nurse has attended a staff education program about delirium. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. Option 1, clients with delirium often appear withdrawn. Option 2, clients with delirium may experience hallucinations. Option 3, delirium may occur in clients who are receiving opioids. Option 4, delirium has a gradual onset occurring over at least 1 year. Option 5, delirium typically does not occur in clients over the age of 60. Option 6, clients with delirium should be frequently reoriented to their surroundings. So let's break this down a little bit. Let's start at the beginning. So we know it's a nurse attending a staff education program about delirium, right? Those are the basics. We know next thing we see are the dreaded words. Select all that apply. We're going to have multiple correct answer choices. Not fun, but we can break it down. I know we can. So we're seeing that it's a correct understanding of the program, meaning we are looking for true answer choices about delirium. anything that is false concerning delirium is going to be incorrect here. So let's go ahead and break down. Well, first off, I want y'all to go ahead and drop those answer choices that you think it might be in the chat. In the meantime, we're going to break down delirium and compare it with dementia, like I mentioned. Compare it with dementia, yes, that's how I said. And then we'll go back to the question and we'll see if y'all got it correct, okay? So let's start with this. Delirium is also known as acute confusional state. It's an acute change in mental status that develops over a short period of time. It's often caused by multiple risk factors that are combined. So, question for y'all out there, what are some risk factors y'all can name for delirium? Leave those answers in the chat below. Okay, let's see. So, some risk factors, let's generalize this a little bit here. Think of things that can cause disruption of your neurological function. This can be sleep deprivation, infection, low blood sugar, pre-existing neurological disease like dementia or strokes, certain medications like opioids or sedatives, and older age. Delirium is, I feel like throughout this live, I'm going to often mix up delirium and dementia, so I really apologize. But that's why we're here today, right? Because it's very confusing. So mind me if I do, okay? I'm so sorry. Delirium is primarily what they call a multifactorial disease process. That being said, it's often caused when multiple risk factors stack on top of each other. When they stack on top of each other, it kind of causes a storm in the brain where they just jumble up the brain and it leads to the manifestations of delirium. So let's look at some client scenarios here where that might be the case. First case, very common one, is an older adult with the UTI. What we have here is the older age present, and then we have the infection. The next client scenario might be an ICU patient or client, and that's receiving sedation. First off, they're in ICU. We're frequently waking them up during the night. Lots of beeping, lots of noises. We have lines everywhere. Your normal neurological function is frequently disturbed here. And then on top of that, sedation, opioids, all the time, just trying to make them comfortable because usually they're on mechanical ventilation. Often delirious. And then another client that we might see this in is a post-surgical client who hasn't been sleeping due to pain. Here we have untreated pain that can make you delirious on top of sleep deprivation, which can also make you delirious. So in these clients, we can see how the multifactorial can kind of add in and cause delirium, right? So when you see this in an NCLEX question, you'll kind of see it as which client is at highest risk for developing delirium. So I don't think you would see them all splayed out together unless it's a select all that apply. But you would see a pretty clear cut. And the most major risk factors are going to be that older age and that neurological disease already present. Okay, let's see. So let's compare that to dementia now. So dementia is usually caused by neurodegenerative conditions or other chronic diseases that affect the vasculature of the brain. Okay, so let's kind of piece that apart. So delirium is caused by something acute. Dementia is caused by something chronic. Okay, that's kind of how we can generalize it in a way. So next step, let's break down manifestations. Question for everyone out there. What are some common manifestations a client with delirium might have? Drop your answers in the chat below as well, okay? I'll give y'all a second here. See some good answers. Okay, so like I said, my background is in neuro and critical care. Like I mentioned above, two things that I see delirium all the time. I've seen it all the time. And it can vary from client to client. It makes it can make it difficult to identify, but once you've seen it so many times, you can pick it up so quickly. So the most common things we'll see are an abrupt onset of confusion that is often characterized by a fluctuation in being hyperactive and hypoactive. So let's focus on that. An abrupt onset of confusion and a fluctuation in being hyperactive and hypoactive. Okay, so what that means, that fluctuation is going from being super agitated and restless and trying to get out of bed, pulling out lines, to being really slowed down and just drowsy and not really knowing where you're at, and then going right back to it again. So it's a lot of back and forth with the client. And like I said, the onset of delirium is quite sudden. It's usually within a few hours to a few days. And contrary to dementia, which can be quite gradual, which is a few months to a few years. So that's a pretty drastic line there between the two. The next thing with delirium manifestation is a reversed sleep schedule. So what that means is that you're awake at night and asleep during the day. That's often a cause for delirium as well. They're not awake at night and asleep during the day by choice. Like I know you might be out there studying for your NCLEX, which is a great time to tell you should really get those 8 hours of sleep in when you're studying those UWorld flashcards, okay? It really helps with retention. But back to sleep deprivation. With dementia, they often have sleep awakenings. So what that means, or frequent awakenings. What that means is that their sleep is fragmented. So versus we have delirium, which is going to be reverse sleep schedule, and then dementia, which is going to be fragmented sleep. So dementia will often wake up during the night and not stay awake all night. Okay, let's see. Next, let's look at thought process with manifestations. So a client with delirium will often be disorganized in their thought process. Their thinking will be all over the place. So an example of this is they'll be talking about one thing and then about another, and they'll jump to another, and they won't really connect at all. They have problems connecting their thoughts and making sense. And this is different than a client with dementia in the sense that a client with dementia is often just having impaired judgment and trouble making decisions. So you often might see a client with dementia just having trouble, like they won't have the best safety advice, right? Like they're both high fall risks, but a client with delirium, their thought process is a little more off, if that makes sense. This is definitely a little bit more of the confusing section of dementia versus delirium, because they can often overlap. The line in the sand is very faint between these two because a client with delirium can often have both. And then a client with dementia, while their thought process isn't disorganized, they're usually just impaired judgment and trouble making decisions. I hope that makes sense. Okay, let's see. So other similar manifestations between the two are going to be hallucinations, irritability, and hyperactivity. However, though, clients with dementia won't have the fluctuation in hyperactivity and hypoactivity. So how we talked about in the beginning with delirium, how they fluctuate a lot and they go back and forth, a client with dementia won't do that. They will often just either be hyperactive and be really irritated and maybe a little cranky, but they won't necessarily go back and forth like you'll see with a client with delirium. Or a client with dementia might also even be having trouble performing certain tasks. They'll be a little slower, but not necessarily the huge swings that we see in delirium. Okay, so let's paint. If I haven't painted a clear enough picture, I want to paint a picture of two different clients now, one with delirium and one with dementia. So we have this client with delirium. So let's say they came in, they're an older adult with a UTI, and all of a sudden they're seeing spiders crawling along the wall, and you walk in and they think that you're trying to kidnap them and you're trying to harm them and stuff, and they're seeing things come off the side of the bed and oh my goodness, everything's bad, and the next thing you know, they're sleeping and they can barely move and get out of bed. That's kind of that back and forth, right? And the hallucinations and the disorganized thinking. versus a client with dementia now, where we might have a client who's just, clients with dementia typically are older of age, so we'll say they're just there for a surgery or something of the sorts. And they might just be like, oh, I'm not home, I'm back in the 60s, waiting to go home to my baby, when in reality, their so-called baby is really their grown kids sitting next to them. So that's kind of that impaired thinking and the forgetfulness and stuff there. If we can kind of see that difference. Okay, so I know that was a huge piece of information about manifestation. So if any of that was unclear, please go ahead and leave that in the chat and we'll try to clear any of it up, okay? Okay, so let's go ahead and let's see how we as future and current nurses can help treat a client with delirium now. Let's talk about interventions. So how can we definitively tell a doctor that a client is experiencing delirium? Leave your answers in the chat below, okay? Wait a little second here. Okay, so we know the manifestations and we know the risk factors now. We think, oh my goodness, my client just might be experiencing delirium. Great. So in order to go tell a doctor that or a healthcare provider or someone that, right, we have to have a objective piece of data or something to chart and document. So the way we do that is by a delirium assessment tool. There's many out there, and the most common one used is CAM, short for Confusion Assessment Method. I focus on this one because it is the most common one, but there's many out there. It really depends on your facility and which one they have in their protocol, okay? So I'm going to focus on the CAM here just a little bit to kind of explain how this tool works for delirium and what exactly we're assessing here when we dive into delirium. Let me get a drink of water real quick. So the CAM consists of 4 questions. The first, and you don't really need to know this for your NCLEX, it's just more just to paint a picture for you and kind of understand the concept, okay? So the first question assesses the mental status changes. It asks the nurse, has the client changed from the baseline status of has the client changed from their baseline mental status? Yes or no. The second question asks, it assesses focus or attention. So oftentimes, I know the facilities I have previously been employed at for clinical have asked like, squeeze your hand when saying the letter A. It's focusing on attention. Can they focus enough to know when you say the letter A in a series of letters? Okay. And the third question is disorganized thinking. So you say a series of questions or a series of commands, and do they follow that appropriately, or do they I think one of them might be, can you hammer a nail in with a hammer, something along those lines of where does it make sense and is it organized is how you assess that, okay? And then it's a yes or no is how you document that usually, okay? So, and the fourth question is level of consciousness. And this is usually just asked, but like the nurse kind of just assesses the patient is, has their level of consciousness changed, or what is their level of consciousness, okay? And you chart or document that. So, and if the CAM or whatever tool you're using comes out positive, this gives us objective data or evidence to go back to the doctor or healthcare provider and tell them, hey, I think now I know my client is experiencing delirium from what, I'm not sure quite yet, but I might have, maybe we can present them with, we kind of go to them with that, with the call, right? And with the SBAR, and we tell them situation, background assessment, and all of that. And we tell them I think it might be because of this, this, or this, and they can help us plan our treatment and work out our nursing interventions now, okay? So let's go into that. Let's see, what are our nursing interventions that we can do as nurses? So frequently reorienting to name, place, time, and situation are all great things to do. This is a good time to mention that with dementia, this is advanced dementia. It's not always recommended though, because you can actually further aggravate a client with advanced dementia with frequent reorienting, okay? But with clients with acute delirium, this is a great time to reorient, okay? Also placing clocks and calendars, not multiple clocks and calendars, okay, but placing a clock or a calendar and the date and time are great ways to help your client kind of stay current if they're experiencing delirium. So if they look up, oftentimes clients think, oh, it's 7 a.m. and really it's 9 p.m. on a Tuesday, and they think it's 7 a.m. on a Saturday. No, so they'll look up at the clock and they'll be like, oh, okay. And they look at the calendar like, oh, okay. And it kind of helps them reorient and kind of get a grasp back on reality, okay? And then oftentimes family pictures just provides comfort for the client and a sense of safety. Distraction from unruly behavior is really great. So not only does this provide safety for the client and for the family, but also safety for us as nurses. So whenever we distract from unruly behavior, oftentimes it's misconceived that you want to use restraints. We don't want to use restraints because this can often aggravate the client more and get them upset more and push them to act out more against you. Okay? So another thing we want to do is promote mobility in a normal sleep pattern. Promoting mobility in a normal sleep pattern will help them get back on track with that reverse sleep cycle that we mentioned before, right? And also reducing noise. Same thing as before. And then give back those glasses and hearing aids if they were taken away. Sometimes they get taken away just because they're really expensive and we don't want to lose them, but we want to give those back because that can further aggravate a client, right? When you can't see, you can't hear, it's frustrating. And a client that's already neurologically impaired because of delirium or anything else, it makes everything worse, right? Okay. All of these nursing interventions provide a sense of normalcy and in the hopes of reducing symptoms of delirium and hopefully shortening the duration of it as well. Unfortunately, though, there's no magical medication we can give to get rid of delirium. Medications can be given to treat symptoms such as severe agitation, but oftentimes these aren't used because they have the effect to worsen delirium in some cases. So we have to be careful, and usually that's a healthcare provider's decision. Okay, so usually as a nurse, we have to let delirium run its course, but our job is to make sure the client stays safe and that we stay safe and that they stay comfortable, okay? And we do everything we can with our nursing interventions to kind of promote a good environment for them, okay? So let's compare dementia again right next to it. So with dementia, there actually is medications they can take. It doesn't cure the disease process, so it only helps slow the progression. So that's one thing to know. With dementia, you cannot cure the disease process. You can only slow the progression. So there is no waiting for symptoms to subside like there is with delirium. Delirium can last for days to weeks to very rarely years, but the key here is that if delirium is intervened in a timely manner, we can hopefully reverse it, right? And it's rarely not reversed. So dementia, though, is usually irreversible. And medications are given just to slow the progression, okay? So lots of information, I know, but we all just might be a little delirious now after all that. But let's kind of recap. We've covered risk factors and causes, manifestations and interventions, and let's look at this. So interventions can be shared between the two. So we can do the same interventions to treat dementia and delirium because they kind of had the same confusion and aggravation, right? But want to be careful with reorienting advanced dementia patients, okay? But they can be distinguished between dementia and delirium, between their onset and mental capacity. One is more acute and the other is more chronic, okay? Okay, so now let's go back to our question. Okay. The nurse has attended a staff education program about delirium. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. Okay, so let's look at our options here now, and let's break them down. So option 1, clients with delirium often appear withdrawn. That one is false. Clients with depression, not delirium, are often withdrawn. A client with delirium would be very talkative and moving a lot, hyperactive. Option 2, clients with delirium may experience hallucinations. True, clients with delirium do experience hallucinations. Option 3, delirium may occur in clients who are receiving opioids. True, clients receiving opioids are at high risk for developing delirium. Option 4, delirium has a gradual onset occurring over at least 1 year. That one's false. Delirium has a rapid onset, while dementia has a gradual onset. Option 5, delirium typically does not occur in clients over the age of 60. False. Even though delirium can affect all ages, older adults are especially at high risk for developing delirium. Option 6, clients with delirium should be frequently reoriented to their surroundings. True, reorienting clients with delirium to their surroundings frequently helps maintain safety and provide a sense of comfort to the client. Okay, so our answer today is 2, 3, and 6. Okay. I think the key here, so I saw a couple people say answer choice 5, and I think the key with 5 here is delirium typically does not occur. So this one is false because it does frequently occur in clients over the age of 60. I know it's kind of a tricky one there. Okay, so great work, everyone. It's definitely a tricky subject with the 2 words. Don't know why they phrased it like that. I know it makes it hard, but y'all did great. I hope this was helpful. If you have any questions, put them in the chat. Hopefully we can address them today. If not today, hopefully on our next Live and Learn. So tune in then. Please be sure to share what you've learned today with your colleagues and share what you love most about what you are with your colleagues and help spread your study tips with people. Let them know. It really helps out, okay? Some people just have one way of studying for the NCLEX and they don't know that there's all these other ways people study. So it's really helpful when you can share that knowledge with your colleagues. We do have a free 7-day trial as well for RN and PN on our website. So make sure to check that out and spread that news around. I'll be back here on Thursday to talk about multiple sclerosis. So tune in then, and I hope you'll have a good week and the best of luck on any exams you'll have coming up, okay? Great job.